Cool. Welcome everyone to the PathCheck Global Health Innovators Talk Series, where we work on crowdsourced computational health solutions. To know more about what PathCheck is, please visit our website at pathcheck.org and to join our ever dynamic Slack workspace. Welcome everyone to the PathCheck Global Slack workspace. Please log on to tiny.cc/PathCheck Slack. And to see the previous talks in the series, please visit tiny.cc PCF Research Talks. So quickly introducing my co-organizing team, so Ramesh Raskar from MIT, Nacy Hudson from Hood Medicine, Tau Pradesh Sethi from IIIT Delhi, and Nina Resik from JSI. Thanks a lot for all of your help and for bringing this talk together. So a quick introduction about what this talk is. So we conduct bi-weekly research meetups with speakers who are creating an impact in digital health with AI, software, and technology. The primary motto of this talk being to drive collaborations in AI for health, cross-disciplinary collaborations with efforts from computer science, medicine, bioinformatics, and much more. With that, I would like to welcome today's speakers, Professor Kushney from UIUC and Professor Pranav Rajpurkhar from Harvard Medical School. Thanks to both of you for spending your precious time with us and sharing your research works with us. For that, I would like to introduce Professor Kushney first for his talk. So Lav is an associate professor at the Department of Electrical and Computer Engineering and Coordinated Science Laboratory, with further affiliations in computer science, neuroscience, industrial and enterprise systems engineering, digital agriculture, and the Beckman Institute for Advanced Science and Technology, all at the University of Illinois at Urbana-Champaign. Dr. Kushney is a member of the Tau Beta Pi, Eta Kappa Nu, and Sigma Psi, and a senior member of IEEE. He was a founding member of the IEEE Special Interest Group on Big Data and Signal Processing and served on the Shannon Centenary Committee for the IEEE Information Theory Society. He currently serves on the advisory board of the AIX Prize. He received the IBM Faculty Award in 2014 and was a finalist for the Bell Labs Prize in 2014 and 2016. He received the 2015 Data for Good Exchange Paper Award, a Best Paper Award at the 2012 SRII Global Conference, the Caposili Prize at 2006 Data Compression Conference, the Best Student Paper Award at 2003 IEEE Radar Conference, and was a winner of the IEEE 2004 Student History Paper Contents. With that, I would like to welcome Professor Lau to share his recent work on social capital of COVID-19. So welcome, Professor Lau, and thanks for sharing.
Great, thanks, Rohan. Let me share my screen. And yeah, thanks for the introduction. A little more extensive than was necessary, but what I want to talk about today is social capital, which is a notion that's been developed in the social sciences and in medicine for quite some time now. And we've been looking at this for a little bit. So what I'll try to focus on is how the strength of communities and other dimensions of social capital are differentially associated with various public health behaviors, including vaccinations, masks, and physical distancing. And I'll try to close by also suggesting how we might be able to strengthen social capital in communities. Right, so just as a bit of a definition, social capital involves the effective functioning of social groups through interpersonal relationships, a shared sense of identity, shared understanding, shared norms, and so on. And it was really popularized by Robert Putnam from Harvard University, who had written this book called Bowling Alone. And at the time, he was trying to argue that the decline of various aspects of community life can be problematic. And social capital is generally seen, in fact, as a form of capital that produces public goods for a common purpose. And since Putnam's original work several decades ago, there's been all kinds of studies in healthcare. Social capital has been associated with public health variables like mortality, obesity, diabetes, rates of sexually transmitted diseases, and so on. And broadly speaking, all of these things decrease with greater social capital in communities. But the relationship of social capital to the spread of infectious disease like COVID-19 had been lacking and so some of our initial work was trying to look at how social capital might impact the initial spread of COVID-19. And more recently, we've been looking at delving into more details of the specifics of social capital. So as I was mentioning, this line of investigation started in the early days of the pandemic in March and April of 2020. At the time, I was on leave at Salesforce Research in Palo Alto, California. So we were stuck in our small apartment there during the initial lockdowns. And so working with Richard Socher, who was the chief scientist of Salesforce at the time, we did this initial investigation. And since I've returned to Illinois now for the last year, we've looked at a variety of other problems, looking at mental health with respect to COVID. The focus of this talk, different public health behaviors. We've been looking at palliative care, also looking at how to improve well-being and social capital through music collaborations, actually, which has been fun. And a lot of this work has been driven by my student Nigtha Hal Ruana. And then also we've been doing some other related things on contact tracing using hypergraph models, looking at predicting outcomes of COVID from electronic health records as part of dream challenges and other related problems. Okay, so so when we were working in kind of March of 2020, we were looking at the initial growth of COVID, and there were exponential growth in a lot of in nearly all the states of the United States. And so we looked at the growth rate exponent as a function of the social capital index. This is a operationalization that was developed by the United States Senate, one of their committees. And so it's been characterized for all the states of the US as well as all the county and county equivalent jurisdictions of the United States. And so what you can observe is that the growth rate exponents are negatively correlated with social capital. And more perhaps strongly, the community health index was even more negatively correlated. Right? And these R squareds are kind of like 0.1 or so. And in social sciences, that's actually a fairly reasonable effect size. And so, so this was kind of interesting. It demonstrated that social capital actually does have an impact. It can lead to less growth of COVID. And this was kind of perhaps unexpected. So if you have stronger communities, you might believe one hypothesis could have been that people want to meet together and they want to interact socially because of the community strength. And so that would lead to greater spread of disease. But here we saw the opposite, that in fact, there was less spread. And you can see that at the county level as well. Kind of strong explanatory effect size R squared of 0.16. And so we started to think through how we might be able to explain this. And so again, the week of March 23rd in 2020, we looked at various mobility indices. And what we observed is that there was decreased retail and recreation mobility and increased residential mobility. So people were staying home and not going out into recreational areas as the lockdowns were imposed. And so it's suggestive that social capital actually provides a capacity to forego interaction rather than compelling people to interact. And so this was our initial finding in March and April of 2020. Okay. As we've been thinking about this a little more, we've thought to decompose social capital into its sub-indices. As I was mentioning, the US Senate had the Social Capital Project, and they defined a social capital metric. But it also had various sub-indices, family unity, which is focused on family structure and marriage and children, institutional health, which is based on trust in institutions measured using surveys and other participatory data. Community health, which is based on engagement in civic life, participation in volunteering activities, voting, and so on. And collective efficacy, which is a measure of inverse levels of crime and violence. And so all of these subindices are combined into the social capital index. But what we thought is let's look at these in more detail, and also look at more specific public health behaviors, whether it's physical distancing or masking, or now looking in 2021 vaccination. So that's what we did. And what we saw was that, first of all, institutional trust is associated positively with vaccination and negatively with vaccination hesitancy. Second, community health is associated with reduced mobility. And third, family unity associates with mobility in residential areas, staying home. Right? And these are fairly large sizes, and you can see that the gap has increased. So this is the percentage of fully vaccinated. So when vaccination started, counties with high institutional trust have much greater vaccination rates than counties with low. Similarly, high versus low masking rates, and likewise mobility in family. And so what we were starting to see is that actually different facets of social capital impact different facets of public health behavior in the response to COVID. And so if we dig into this even further, we can look at a variety of public health behaviors, vaccination and vaccination hesitancy, always wearing masks or never wearing masks, a general notion of mobility, and more specifically in retail and recreation versus residential. And so we see the different dimensions of social capital, whether it's community health or family unity or collective efficacy. They contribute in very different ways to the different aspects of public health behavior. So it's kind of interesting that that we find this. It's not a monolithic notion that there's just one notion of social capital and it impacts all of these behaviors, but in fact, there's different sub properties. And what that suggests to us is that in fact there's kind of a multiple layer or a Swiss cheese model that that emerges. I think many of us have seen this Swiss cheese model of defense. Based on physical distancing, quarantining, vaccination, masking, and so on. This was largely developed by Mackay, a virologist, and popularized in the New York Times. But we can take the same idea that's emerged in the safety literature and actually develop a social capital Swiss cheese model. And so we see that all of these different facets, just taking the radar plots I had before and stacking them up leads to this Swiss cheese model of defense based on different aspects of social capital. So that's what our findings are, and it raises a natural question: are there ways to build social capital in communities and improve global well-being at the same time? And in fact, we're working on exactly that right now. We're building a platform for music co-creativity. So even if you're socially distant, you can work with other people to compose new music together. And working together on creative activities actually leads to greater connectedness, greater mastery, and greater autonomy. And those are the three main drivers of well-being as per various aspects of positive psychology. And further, they have been demonstrated to improve social interaction and social well-being. Right? And so what we've been now working with a lot of community groups and to use our technology, and also have a startup that's trying to deploy this technology out and see if we can actually make stronger communities. So let me stop there.
Awesome. So thanks a lot, Priscilla, for sharing that. And yeah, I'm sure there are like a lot of questions out there, but we can go to it after Pranav's talk as well. So thanks again. So with that, I'd like to introduce Professor Pranav Rajpurkar from Harvard. So Pranav Rajpurkar is driven by a fundamental passion for building reliable AI technologies for biomedical decision making. His lab at Harvard approaches biomedical problems with a computational lens, developing AI algorithms, datasets, and interfaces that cut across computer vision, NLP, and structured health data. He's collaborated with clinicians across medical specialties, including radiology, cardiology, and pathology, to make some of the first demonstrations of expert-level deep learning algorithms and their effects on clinical decision-making. He co-hosts the AI Health podcast and co-edit the Dr. Penguin AI Health newsletter. Further, he instructed the Coursera course series on AI for medicine and founded the AI for Healthcare Bootcamp program. Previously, he completed his PhD co-advised by Andrew Ng and Percy Liang from Stanford, from where he also received his bachelor's and master's degree in computer science. With that, Professor Pranav, welcome to the event.
Hey, thanks for the very kind introduction. I want to talk today about a topic that's near and dear to my research, which is the development of AI for medical imaging applications towards helping doctors in the clinic. And I thought I'd focus today on a question that comes up very often in this field is this going to be a competition or a collaboration? I think a key question that's driving a lot of researcher is thinking about how can we make medical AI, which we have shown over the last few years, which we have understood, does have the ability to make impact. How do we go about making that impact as part of routine clinical care? And today I want to focus on two components of that, two pieces that I consider important foundations. The first is the development of models that perform as well as experts. And the second, which is just as, if not more important, which is studying the effect on the clinicians with AI support. So I want to start with talking about the first of these aspects. There have been recent advances, as recent as 2016, where we saw the first demonstrations of deep learning algorithms that performed at a level comparable to medical experts. And within the span of a couple of years, there were demonstrations in a variety of fields, including ophthalmology for detection of diabetic retinopathy from retinal fundus photographs, in dermatology for detection of malignant skin lesions, and pathology for determining whether breast cancer had metastasized to the lymph nodes. And my personal academic journey at the intersection of AI and medicine began with looking at the electrocardiogram and asking whether we could look at a electrocardiogram that was recording the heart's electrical activity over time on about a data set of 30,000 patients, whether we could detect arrhythmias or abnormal heart rhythms from that ECG at the level of cardiologists. And here we showed in this particular study that across a wide range of classes, we were able to perform just as well, if not better, than cardiologists at these tasks. This was an algorithm that was later FDA cleared in 2019 and was used in the workflow for giving patients an understanding of what their heart's electrical activity looked like over time as part of a company called iRhythm. Another study that I had the opportunity to be involved in was looking at whether we could look at chest x-rays, which are one of the most common medical imaging modalities. It was shocking to me that there are 2 billion chest x-rays that are taken per year. And from chest x-rays, determine whether there are one or more of several diseases present on that chest x-ray, and whether we could do that as well as a radiologist could. And that's what we showed in this particular study. And the reason that we were able to do this in 2016, 2017, excuse me, is that there were advancements in both AI algorithms and curation of data sets. On the algorithmic front, there were several improvements in convolutional neural network architectures and the training of these algorithms that were important. And on the dataset front, there's really a focus on efforts and pipelines for data collection and labeling, which have really driven these algorithmic advancements forward. I think for us to make progress, and this was recognized at the time, the model really has to change from, is a model performing as well as a clinician on a control set, to, if a model is being used by a clinician, would that combination perform better than when the clinician did not have such assistance? And let's try to make that close to the workflow of the clinician in their day-to-day tasks. So I want to walk through a few examples of what this setup could look like. At the very basic level, you could consider a simple combination of a model and a doctor. And here's an example of that. So here we were looking at assessing the survival of embryos at 2 to 3 hours after thaw in order to try to predict whether the embryo will survive in 25 hours. And as part of this, we have a deep learning model that's trained to do this, and we're about to compare that with the embryologist and then the combination of the model and the embryologist. And we start off with a very simple combination setup where you have a deep learning model and you have an embryologist, both ranking whether an embryo will survive, and then you average their ranks. So a very basic combination. The embryologist is not looking at the model output. We're just aggregating them together as a post-processing step. And here we see these bar graphs show at 2 different time points, 2 hours and 3 hours. We're able to see that the ensemble model, which is just a model by itself, is performing better than the embryologist on one time point, whereas on another, but the combination of the two is always doing better than either alone. So that's very hopeful. But in some ways, you want the model output to be looked at by a doctor for review. And so in this particular study, we're setting it up such that that's the workflow, where here we're asking radiologists to interpret NMRIs with deep learning assistance, where they get to see 3 probability outputs, one for whether or not the study is normal, one for whether there's an ACL tear, and one for whether there's an MCL tear, which are 2 pathologies we care about detecting from NMRIs. And on this setup, what we do to measure the impact of model assistance is we have a set that's read with model assistance, and the same set is read without model assistance after a washout period. And the radiologists are split into 2 groups, and one group starts with model assistance first, one group starts without model assistance first. And then now we're able to measure the difference of performance with and without assistance. And here we saw that on one of the pathologies, specifically for the ACL tear, you can see that the specificity of the group went up by 0.05. And what this translates into is for about 100 people who don't have an ACL tear, the radiologists with model assistance are able to more correctly pick up 5 of them. And the implication of this is, you can imagine, fewer people need to be operated on, and there's a motivation here for reducing the cost of care for those patients. One other assistance setup, which makes even more sense from the perspective of interpretability, is to have a segmentation model. Here, we're not just showing probabilities, we're in fact highlighting a region of interest where the radiologist would pay attention to say, here's what you're looking for. And as a test case, we're looking at head CTAs, which are used to evaluate whether there are clinically significant aneurysms which are balloons that you want to be able to detect before they're at a risk of rupturing and bursting, and that can lead to poor outcomes for those patients. So here we have a setup in which we're having a model highlight those aneurysms and provide that to the radiologists. And we have a similar crossover study design where there are reads that are performed unaugmented and AI augmented. And here we see a much clearer improvement in sensitivity, specificity, and overall accuracy, where with augmentation, we're able to pick up a lot more of these aneurysms, with the hope here being that the radiologists are just missing fewer aneurysms and people who need care can receive that care. One of the interesting questions here was, who benefits more from AI? Is it the case that we're able to identify particular people who are able to benefit more, or is it the case that there's uniform benefit across people? And the results have strong evidence for that. The improvement is not uniform. In fact, there is probably a lot of factors that are creating different amounts of improvement. So I'll bring our attention on to radiologist 4 here, who you can see in yellow was their unaugmented accuracy, and in blue was their augmented accuracy, and for whom we can see this big improvement in performance. While if we look at radiologist 5, who amongst all the radiologists had the best performance unaugmented, had very similar performance augmented, and so had the least improvement. And what this graph points to is that the radiologists who benefit most from AI are the ones who are performing least well without the algorithm. And that points us in the direction of maybe the deep learning algorithm assistance will be an equalizer of sorts for clinicians. And to test this hypothesis, one of the other studies that we performed was outside the domain of radiology and the domain of pathology. And pathology is an interesting domain because, unlike radiology, where there has been a lot of movement towards having everything digitized, pathology is still undergoing that transition. So there need to be innovative approaches to integrating into the pathologist workflow to be able to provide AI assistance when digitization is lagging. And here we have a setup in which we have a pathologist take a screenshot on their slide viewer, or be able to take a snapshot under their microscope and upload that onto a web platform, which then is able to perform a useful task based on what's uploaded. In this case, we were distinguishing between 2 subtypes of liver cancer, and then incorporate that model output into their prediction to make a diagnosis. And here we have a similar setup of being able to evaluate what happens with and without assistance. The one difference here is that we are adding in a couple of training cases to be able to have the doctors get used to this assistance format. And then in blocks of 10, we're showing cases that are either assisted or unassisted to be able to evaluate the difference. And what we see here is that if we break down the expertise of the pathologist, we see that there is a group here, which is the trainees group, which experiences the most improvement with assistance. And we see this pathologist not otherwise categorized group that actually has a drop in performance with assistance from 0.969 to 0.931. And so this confirms this idea that there is something about the level of expertise, at least, which is influencing the utility of the AI tool. So those are the 2 foundational blocks that I wanted to share with you today. And I hope that it's clear that there is a lot of work to do, and in turn, a lot of promise for these tools to make a positive effect on on patient care. I think some of the directions that we need to consider for the future are how do we design these effective clinician AI setups? How do we think about medical data curation in the real world? And how do we design algorithms that are efficient in their use of labels, as that represents a key bottleneck to be able to scale the number of tasks that we can accomplish in the near future? I'll end by saying I hope more people join in these efforts towards this goal. There's several opportunities, several resources, including an AI for medicine specialization, which I instructed on Coursera, a weekly newsletter that I co-edit to keep track of the latest AI plus health research, and also the AI Health podcast, which I co-host, where we talk with entrepreneurs, doctors, and investors about what's happening on the industry side of things. That's where I'll end. I do want to thank all of the people that I've had a chance to collaborate with, both on the student and the faculty side, and the work that I presented today was done by a large group of these people. And I'll end there. Thank you for having me.
Thanks a lot, Professor Pranav. That was really cool. So I guess we can move towards the Q&A right now. So if any of the panelists have any questions, feel free to unmute and ask directly. And if any of the attendees would like to ask a question, please feel free to use the chat or Q&A. I can start with a few of the questions that were sent across to me. Right. So I guess one of the first questions I got was for Professor Love, which was on the social capital. Were there some differential impacts seen on vulnerable population or people of different races, or was it possible to look at the study in that direction?
Yeah, that's a good question of looking at disparate impact on different subpopulations, whether or otherwise. Unfortunately, the social capital indices are geographic. They're not broken down in those dimensions, and so it's not something we could evaluate. But as I'm sure you're familiar, there is a lot of work showing that the impacts of COVID has been disparate, and so a lot of our focus on the community building side has been working with Black communities in the Midwest, in Chicago, East St. Louis, here in Champaign, and in Dayton, Ohio. And so working with those communities has been really a good experience for us, and I think we're making some impact.
Interesting. So another quick follow-up question is, from what we understand about social capital and the new Swiss cheese model of social capital, what is it that we can take away as the most important fact for COVID or for any coming pandemic?
Yeah. So the main kind of actionable insight is that one can work on different dimensions of social capital in different communities, and collectively they can make an impact. So if it's easier to move the needle on institutional health in a certain community, one can push that quite forward, and that would help with vaccination. If a family is easier to work on in a given community, that can help with mobility and masking. And so if we think of these different layers as operating, I mean, they're correlated, but they're also somewhat orthogonal. And so we can work separately depending on what is easier to impact in a given community. And so broadly speaking, I mean, social determinants are varied, and one can focus on different ones as one can.
Mm-hmm. Okay, that makes sense. Okay, I guess there's one question from the audience. Yeah, ma'am. Hi, Monica, do you want to ask a question?
Yeah, hi, great talk for now. And I have a couple of questions about generalizability. So first one's like, how well do the deployed models do in hospitals, as in when they see new data? And secondly, how do we measure this against a radiologist evaluating the image?
Yeah, that's a great question. I think what's clear is that how these models generalize to different setups from which they were trained seems to be a big function of the scale of training data that was used and the source of that training data. It's clear from commercial efforts that have tried to have a focus on collecting diverse data from different sources as part of creating a large training set, have been able to demonstrate that they're able to generalize across sites pretty well, while efforts that are using smaller and more homogeneous data sets have not been able to overcome the difficulty of generalizing across patient populations, which is why I think there is such an important need to be able to going after the creation of real world grounded data sets that are generated from heterogeneous data sources. And if not at the scale required for the training, certainly at the scale required for evaluation. One question to answer your second question, which is a question that comes up very often after these models are deployed, is how do you now enable sort of a comparison that allows us to benchmark how this is doing in practice? And there's no established standard for this yet. One strategy that is leveraged is doing a random sampling of cases when the model is deployed, and doing an overread on that. And on that overread, we're able to compare what is the difference that was what was the difference in the interpretation between between when the tool was used and an overread, and that's one way to do it. Another useful way to track how these models are doing is to have the ability for radiologists to override what the model is saying, and then measure the number of times the doctor is overriding and seeing if that increases over time or decreases over time. Even this, of course, has an issue that you can imagine, that doctors get more used to a particular tool and more likely for that system to have automation bias, where after a while, mistakes that may be made by the model are no longer corrected by the doctors. So there are lots of design considerations here, and certainly a need and a requirement for measuring how models do in practice.
Great, thanks for that. Thank you so much. That really makes sense, and it also kind of like works in parallel with physician burnout and etc. That after a point, radiologists or doctors can't really get very accurate representations because they're like too tired, and it's actually like a real issue, and that's how these errors come up in reports. So I think it's like a great way to try reducing that. But thank you so much, and thanks, Rohan.
Right. So there is another question from Tau Pradesh on the chat. So I can just quickly read it out. Love, thanks for the great work. Social determinants are indeed the most important factors in any successful implementation of healthcare interventions. My question is, how do you design efficient interventions, as the effects of working with social determinants may take decades to show up?
Yeah, Pritesh, I mean, you've captured the difficulty. This is a long-term question, building up the strength of communities. It's not something that can be deployed in a month or in a year. It takes time, but there are, various things that can be done. Actually, creating venues for social interaction has been demonstrated to work pretty well for improving social capital. So building parks and sports stadiums and things like that. So that's one possibility. We did some work with Rumi Chanara from NYU Global Health along these lines some years ago. More focused on obesity, but the same ideas hold here. And also, a related question is kind of physical distancing seems to lead to loneliness and degrade social capital. And so there's this question of social capital provides a bulwark initially, but then it might degrade. So how do you build it back up for the next pandemic or the next public health challenge? Right. And so that's, I think, a very open question. And one of the reasons we're exploring this kind of co-creativity platform to help people work together and create art and music together is to explore whether that might have an impact in a quicker manner, actually. Actually interacting even remotely might help with that. So yeah, I think you've captured it correctly. I mean, it takes time, but I think strengthening communities is the long-term public health issue that's super important.
Okay, interesting. So I had a quick follow-up question to that. So based on your presentation as well, it was shown that trust is an important factor. Trust in institutions or trust in the medical community was an important factor. And I would assume that it would be differential across different strata of the society. Did you see something like that, or was that data not available?
Right, that's not seen in our data, but and also just to be clear, our work is associational; it's not causal. So it's seeing associations, but it is clear that there are differences in all these social capital metrics for different subpopulations, whether it's institutional trust or family and community health as well. So for sure, it follows logically that what you're saying is true, but we didn't demonstrate that. So I won't say it strongly, but I agree with your sentiment.
Okay, that makes sense. Thanks a lot. So I had like few more questions, which was for Professor Pranav. So one was along, I think it's follow-up to maybe what Monica had asked, is we've generally seen even in the COVID-19 chest X-rays or in other medical imaging data as well, that there were like few spurious correlations where, let's say, the model sort of tagged the hospital ID or some other information of who the person was to determine whether the person was cancerous or was COVID positive, etc. So are there some potential ways we could mitigate these sort of biases? And what is probably the best way to do this in an explainable way?
Yeah, I think it's an important question. I think one of the ways that we get around shortcut learning as a challenge is to expand the amount of data that we're working with to train these models. Now, that's not always possible. You can imagine another thing to just do, which might not provide a solution, but at least finds out the problem, is to change what we're using to evaluate models. So if you have a data set that's from a single institution, you're unlikely to find out if there's a spurious correlation that was exploited by the model unless we go and apply it to another institution. There is also a difficult distinction to make between spurious correlations and correlations that we do want the model to learn about. For instance, if we know that a patient has lines and tubes, a person would be able to infer that this patient was sick and likely in the ICU, and thus actually modifies their prior based on that information. Same if I know that the patient is coming from this particular clinical context versus not. And right now, if a model were to leverage that, we would have to have the right kind of evaluation setup to be able to distinguish between whether it's a correlation that we want to exploit and a correlation that we consider to be problematic to exploit. the issue of explainability is related, but not entirely the same problem. You can imagine two scenarios here. One in which the models are working just fine, but the methods we have for post hoc explaining the model's decisions are wrong, in which case that's the piece we need to work on. Or the second scenario in which these methods to be able to explain the models are correct, but the model itself is wrong. And right now, those are very hard scenarios to decompose. And we've shown in some of our recent work that if you look at one of the most common methods for determining if a model is paying attention to the right regions of an image, which is gradient-based class activation maps or GradCams, we actually find that they're not as good as radiologists at being able to localize the pathology. So in terms of being able to say, I call this a enlarged heart because I was looking at the heart, you're able to see that a radiologist can just, highlight the heart, but a model may not do that just as well. It might exploit some of these correlation factors to be able to get at that decision right now. So that's broadly the set of challenges that we have to tackle.
That makes sense. Thanks for that. So another follow-up question was, you did mention about how we could do this as an augmenting or a collaborative form rather than a competition. So in the examples that you had shown, was it sort of a binary decision where it was either accepted by the clinician or rejected, or was it sort of weighted, or was there other ways of determining which one would go ahead in terms of a contradiction?
Yeah, so there are two parts here. One part is the prediction, which is the likelihood assignment by a person, and the other is a decision that's made based on that likelihood assignment. And so we can ask a physician, how likely do you think this is this particular disease? And they can give their score from 0 to 100, and we can show them a score from the algorithm. They also have to ultimately make the decision, what do I do with this? Do I actually convert this into a follow-up action, or a treatment action, or I don't do anything about this action? And we don't have models making those decisions right now. We have models making predictions. We have clinicians that are also outputting their predictions, and that's what they're putting into a report. But in some clinical contexts, we also have to make decisions. And I think that's a distinction that's not made right now, but it should be more often.
Okay, makes sense. So there is another question in the chats, which is from Professor Srinivasa from India. So how to work on this in India with the 1.3 billion people? And can we do this with very small and sample data, maybe taken from long distance, for instance, drones? So I guess he is looking for an answer from the both lines of work that you had presented on, like the social capital parts of it, as well as the AI for healthcare. So.
Yeah, I've never thought about remote sensing as a methodology. I mean, there's a lot of work on things like poverty assessment using remote sensing data. I mean, there's a lot of work on mobile phone data to understand social networks, which is a kind of a form of remote sensing, but with embedded sensors in a way. And one could imagine kind of using both of those to assess the nature of social interaction. And I mean, there's some relationship between the built environment and social capital as well. But I think this is largely unexplored. I don't think there's any work in this area, so it might be kind of interesting to see what can be done.
I'll just add on the medical imaging AI front. There's actually a lot of exciting work happening in India towards the deployment of algorithms across a variety of hospital systems in India to be able to assist radiologists in their workflow and work towards trying to make assessments where there are no radiologists available. A lot of encouraging work going on there where we're not just talking about research phases, we're talking about actual deployments on real people.
Yeah, one other thing I just was remembering is one of my relatives, Professor Rajpurkhar from Brown University, he's a political scientist and he studies communal violence. And so he's been, for the last 20 years, been looking at kind of participation in activities like Lions clubs and Rotary clubs and things like that. One could imagine, I mean, leveraging the style of research that he does to understand public health. In fact, I should reach out to him and see if there's some interesting possibilities.
Okay, thanks. That makes a lot of sense. So yeah, I guess Mr. Srinivasa was like commenting again on this is like huge crowds who might not have access to modern medical facilities as well. And yes, definitely, Professor Srinivasa, I think that'll be awesome. So I've asked almost all questions that were sent to me and that I had prepared for the talk. But if there are any more questions from the panelists or the participants, please feel free to type in the chat or unmute and ask.
Yeah. Pranav, I'm curious about one thing. So in a lot of domains, there's a lot of professional prestige associated with being a radiologist or an ophthalmologist or an astronaut or things like that. And there's this very nice example. Neil Armstrong, when he was landing on the moon, he turned off his autopilot and landed by joystick because he felt like, I mean, I'm the human, I should land on the moon myself. Like studies of the Apollo program suggest that, and every further Apollo astronaut did the same thing. They turned off autopilot afterwards while they were landing. And I mean, studies suggest they did worse as humans than the autopilot would have done. I'm just curious, have you seen this kind of phenomena where the professional prestige, the desire to be the human in control limits the applicability of AI technologies?
Yeah, that's a good question. Certainly from the perspective of liability, the approach that currently I would say is more often than not being used is have the AI tool still be a decision support. And the final approval is still given by the radiologist who has the ability to make any modifications they want before signing off. And the idea here is that the liability doesn't change in this particular model. There is an exception to this. There are a few exceptions to this. One notable one is the way diabetic retinopathy by a company that just got CMS coverage maybe last year, a couple of years ago. What they did was had a fully autonomous deployment where they're in these centers where patients walk in, get their screening exam, and then if they have anything picked up by the algorithm, are referred to a specialist. So I think from a screening setting, I could see having a completely automated setup be used first. In terms of whether people will care that they're not making the final decision, I think the answer, as far as I understand it, is no, if there's no one doing it currently in the first place or can't keep up with the volume. But yes, if it is something that's considered a complex diagnostic decision that requires more information that is just present in the part that the AI has access to.
Yeah, okay. So it's largely driven kind of by the moral crumple zone, right? The liability in some ways, and then regulatory reasons. Yeah, I mean, part of the reason I was asking is we've done some theoretical work recently showing that in certain settings where you model humans with certain psychology models of decision making, that if the human goes first and provides advice to a machine and the machine makes the final decision, that can actually outperform settings in the opposite case where the machine provides advice to the human who makes the final decision. And we have ways of characterizing when each of the two configurations are better. So yeah, I'm just curious if it's ever tenable to actually do the opposite. And it sounds like, at least in screening, maybe there are possibilities.
Yeah, I think so, and I'd be curious to look more into that work, because I think there might be some things we can learn from there as we're pushing forward these systems.
Awesome. I think it's more of a generic question from Professor Prasanna is, can we use AI to predict mutations that are happening in the current COVID-19 or any other pandemics for that matter?
Yeah, I mean, I would imagine so, but I think it really requires some expertise of epidemiology together with AI. I think we don't want to be armchair epidemiologists here and say we know what to do, but I think one could imagine working with experts in the field to do this.
Makes sense. So, right, I guess we're close to the ending time, and so thanks once again. Thanks to both Professor Love and Professor Pranav for spending their time with us and sharing all these insights. And we look forward to having you for further talks and collaborations as well. And thanks again for all the listeners and panelists for joining in. Thank you.
Thank you.
Thanks.